This webinar is being recorded, and we will have both the audio and the video available in our YouTube channel. In a couple days, or maybe later today, we will share the link to the recording. Do not hesitate to contact me or my colleague, Ximena Armendaris. She's part of the webinar today. And if you have any problems, and just to remind you to keep your microphones turned off. We are going to have for this meeting a feature called Wordly. In the chat, you have a link to Wordly. Wordly is an artificial intelligence translator that if you click on the link that Ximena has published, you will be able to open it, and you can have the webinar translated in English, French. We have 50 languages, Spanish, Arabic, you name it. So you have 50 languages that you can choose from, and you can use Wordly if it's easier for you to follow the presentations in a different language. I have no more housekeeping announcements. So Dr. Metin Gulmesoglu is going to be our moderator today. And so Metin, the microphone is yours. Thank you.
Thank you, Milka. And you know, these days when you have podcasts, they sometimes introduce new softwares and things like that. It sounded a bit like a commercial on a podcast. But nevertheless, it sounds very useful, Wordly, and I hope people can try it. I will certainly try the Turkish version of it during the podcast. Thank you, everyone, and welcome to this webinar on implementation studies, experiences from the field on implementing postpartum hemorrhage prevention and treatment interventions products. Most of these studies were supported by MSD for Mothers. We kindly acknowledge their support. And the studies that are going to be presented have been put together and compiled in a supplement in the Journal of International Journal of Maternal and Child Health and AIDS. It's an open access supplement, so everybody can access them, and we will show you the links to the supplement as well. We have 60 or 55 minutes in total for the webinar. So without any more delay, I'm going to introduce our first speaker, and the first speaker is from Concept Foundation, Sarah Rashwan, and Sarah is going to give the experience or share the experience with our 5-country study, and we will follow with other implementation experiences. Please enter your questions in the chat. Unless we have few minutes in between, we will try to respond to them in the chat, and we will aim to have some time for open discussion and Q&A at the end of the webinar as well. So, Sarah, over to you. Thank you.
Thank you, Metin. Good morning, good afternoon, everyone. This presentation will provide an overview of one of the implementation research studies featured in the supplement, which is a heat-stable carbetocin and tranexamic acid implementation pilot study, which was supported by funding from MSC for Mothers. So Concept Foundation conducted an implementation research study in 2022 with the objective of assessing safe and appropriate use of heat-stable carbetocin, or HSC, for PPH prevention, and tranexamic acid, or TXA, for PPH treatment, as well as their integration into routine care. We aimed to address this objective through assessing the feasibility and acceptability of introducing the two medicines in 5 sub-Saharan African countries, which are Burkina Faso, Ethiopia, Ghana, Sierra Leone, and Uganda. We partnered with national organizations, hospitals, and universities to conduct this study, which are listed on the screen. To briefly summarize the methodology, this was a mixed methods study, and the stepwise approach we took included collecting baseline data over a 2-month period on the active management of third stage of labor, obtained directly from the patient registers. This was then followed by training of healthcare providers at the study facilities on safe and appropriate use of HSC and TXA. And then the medicines were introduced into the study facilities, and the same data was collected over 2 months for the implementation phase. And the principal investigators and assigned seniors carried out weekly monitoring and monthly support supervision across all the study facilities. Combining the 5 countries, we managed to collect data on over 25,000 women who delivered within the study period, and 140 healthcare providers in total were sampled for the qualitative research portion of the study. Also, we had a total of 9 BMONC and 10 CMONC facilities, and 961 healthcare providers were trained on using HSC and TXA. Moving on to the results, I will firstly go through the key quantitative findings. So the bar chart on the left shows that at baseline, the percentage of women receiving prophylactic uterotonics was in general very high in all of the countries and in both facility types. So most were more than 90%. None of the facilities had HSC at baseline, and oxytocin, misoprostol, and oxytocin in combination with misoprostol were the most used prophylactic uterotonics at baseline. During implementation, the bar chart on the right shows that HSC was the most used uterotonic for PPH prevention in both facility types, as it was administered to over 87% of women in all of the study countries. The decision to administer heat-stable carbetocin was made by the healthcare providers, and it was not reinforced for the purposes of the study. The TXA data demonstrated that at baseline, most study facilities had no or limited access to TXA because it was either not available or limited access, or because they lacked awareness of TXA use for PPH treatment. During implementation, TXA use for PPH treatment was generally low in all of the study facilities, but it was aligned with the WHO recommendation of early administration of the first dose. Other key findings from our study included no adverse events were reported from the use of HSC or TXA during study implementation, and the ampule counts confirmed no cases of contraindicated use of HSC for labor induction or augmentation. Also, there was no self-reported hesitation by healthcare providers by using either medicine post-implementation in all of the study countries, with the exception for Burkina Faso. There was a slight increase in hesitation over the use of TXA, and the reason was the slow administration of the drug, which requires caution. And finally, self-reported methods of blood loss showed that 75% of healthcare providers sampled across the 5 countries visually estimate blood loss. Moving on to the qualitative findings, we conducted a thematic analysis to deduce themes from healthcare provider responses. 3 themes were identified, which overall reflected a need for capacity building and training on the use of HSC and TXA within a holistic model of care, of PPH care. Some of the responses from the healthcare providers included a desire to receive training on early detection of PPH, also highlighting the issue of compromised cold chains. And as mentioned, healthcare providers in Burkina Faso identified further training needed on the use of TXA. The key takeaways from our study are that, firstly, HSC and TXA were safely and appropriately used according to WHO recommendations in all of the study facilities. Secondly, the fragility of cold chain integrity and storage was a real challenge for all of the countries. And this highlights the importance for more widespread use of heat-stable medicines and supplies to strengthen the quality of PPH care. Thirdly, health information systems need to be improved for reliable data capture. And this is especially critical in BMOG settings where record keeping is practically difficult to try and capture all of the events that occur during childbirth. And fourthly, systematic introduction efforts, which include national policy change, EML inclusion, registration and procurement of quality assured products, clinical protocol updates, on-site training, etc., are all crucial for successful implementation and scale-up. And quickly to go over the strengths and limitations of our study, the strengths of our study include assessing the feasibility of concurrently integrating 2 new and lesser used PPH medicines into clinical care and identifying similarities and differences between countries and facility types. And we also generated evidence on the acceptability and feasibility to introduce the 2 medicines into diverse contexts and highlight in-country realities as it pertains to cold chain capability, PPH training gaps, and record capture systems. In terms of limitations, there was poor record capturing patient registers. The data collection duration was short, and we only had a snapshot indication of facility characteristics as it pertains to product stockouts and electricity availability. But we would like to sincerely thank all of our partners and local data collectors for all their efforts in completing this study. And a final note, I just want to highlight that we have a review article by Concept Foundation that is featured in the supplement. It's titled A Tale of 2 Medicines, The Need for Ownership, End-to-End Planning and Execution for Development and Introduction of Maternal Health Medicines. The paper makes the case for an end-to-end approach to timely introduction and ultimately end-user access to essential maternal health medicines, using HSC and TXA's access pathways to examine the shortcomings of a lack of an all-encompassing end-to-end approach in the maternal health field. So we very much encourage you to read the paper, which you will find in the supplement. Thank you very much.
Thank you, Sarah, and thank you also for sticking to the time. I don't see any questions in the chat, so let's move on to our next speakers. And the next presentation will be from the Smiles for Mothers team, and Daisy Ruto from Kenyan team, and Olatunde Amode from the Nigeria team. Daisy and Olatunde, over to you. Is this your first slide? Yeah. Please go ahead, Daisy.
Yes. Okay, are you able to see my slide well? Thanks, Metin and Thank you to Milka and the team for inviting me to speak. This paper, also featured in the supplement, is from Kenya on the introduction of heat-stable carbetocin for PPH prevention in the public sector hospitals. And it focuses on provider experience and policy insights. We were supported with funding from MSD for Mothers, and we were 3 consortium partners, JPIGO, Mackenzie, and HealthStrat, that was able to do this work. So just as an introduction, this was our intervention package. And in this intervention package, we focused on 3 main themes: policy change, and this included inclusion of WHO recommendations on uterotonics into various documents, including the National Obstetrics and Prenatal Guideline, the IMONC mentorship package, then the MNH standards, and the KML in Kenya. And then we were also supporting development of national clinical protocols, all provider protocols, and also program implementation that included training of healthcare providers. We were able to train a total of 442 and disseminated the WHO recommendation across 10 counties in 39 level 4 facilities. We were also, as part of the implementation, developed client literacy materials for the clients using a human-centered approach. And lastly, we were introducing heat-stable carbetocin across these 39 facilities in 10 counties, a total of 9,970 doses. So we were able to do an implementation research, which was part of a larger study, and this focused on understanding the PPH prevention knowledge and experience, including heat-stable carbetocin and use in the public health sector within 10 facilities. Our focus was policymakers and healthcare providers. Our research design was a mixed method study with both quantitative and qualitative components. And we did conduct this study with the healthcare providers in 10 counties and the policymakers at different levels, at the national level as well as the subnational levels of the healthcare system. So in terms of the objectives, we aim to understand health system factors that need to be considered for successful introduction of heat-stable carbetocin in the public sector. And also our focus was to measure the change in healthcare providers' knowledge, perception, practice, and experience before and after the training, including use of heat-stable carbetocin. So I will share briefly on some of the results. And we wanted to know, as we started this implementation research studies, the awareness of heat-stable carbetocin among the healthcare providers. And at baseline, we found that only 18%, about 18% of the healthcare providers were aware about heat-stable carbetocin. And this 18.1% of the healthcare providers is because we do have the private sector molecule within the country, and a few of them had been exposed. By endline, practically all the service providers were aware about heat-stable carbetocin. We also sought to find out their knowledge about heat-stable carbetocin, also comparing baseline, what they knew, and also at endline. And some of the factors that we looked at was awareness of storage recommendations, and we can see the improvement to over 98%. And for all these indicators, awareness of using a single dose, as well as awareness on the recommended dose or route of administration, all this was able to improve from the initial baseline, the darker green, to the end line, which was all above 90%. When it came to practice around the heat-stable carbetocin, we asked them a specific question around heat-stable carbetocin storage and transportation, and we wanted to know if they knew that recommended temperature for heat-stable carbetocin in these two scenarios of storage and transportation. And the same applies that at baseline, only about 47.5% knew correctly that heat-stable carbetocin needs to be stored below 30 degrees, but at end line, the providers, 98% were able to correctly point out that the heat-stable carbetocin is stored below room temperatures. And of course, we did have a few that at baseline did not completely know, and there was also other responses, no responses, and others who were able to say, to provide other responses. For heat-stable carbetocin administration for PPH prevention, at baseline, only 1% of the providers knew that heat-stable carbetocin can be provided for prevention. But again, at end line, having done the intervention, trained the providers adequately, they were able to correctly identify that it's for use for PPH prevention as opposed to treatment based on the WHO recommendations. So in terms of their perception and experience on heat-stable carbetocin, the providers, again, looking at the range of these particular questions, whether the heat-stable carbetocin was effective in preventing PPH, heat-stable carbetocin has minimal side effects and can be stored at room temperature, has sustained effective contractions, and whether it was easy to distinguish it from the other eutrotonics based on their packaging, or whether it was easy to administer. Again, we can see there was a huge difference between the baseline. For instance, how easy it was to administer at baseline. The providers at 45.9%, but at end line, after using the heat-stable carbetocin, this improved to 93.6%. So overall, all these indicators were able to improve with the intervention that we were providing. We also talked to the policymakers who we talked to at the national as well as the subnational level. And these were different types of policymakers. But just to share just these two quotes which the policymakers mentioned, one of them who was from one of the counties, that is an urban county. This is the capital city, Nairobi County. The policymaker said that, I think preparation is very important. Once the healthcare providers are taken through a very systematic introduction, they'll be able to accept use of the heat-stable carbetocin. And another policymaker, again from our Kenya Medical Supply Chain Agency, this is our national public sector supply chain, said that there has to be stakeholder buy-in, because that's the most important, especially at the national level. Counties must be fully convinced that this product will add value.
Easy. You have 1 minute left. I just wanted to check if Olatunde is going to speak, or you have 1 minute to fill the 10 minutes, huh?
Yes, and this is my last slide. So in terms of the implementation, there was clear differences between the baseline and end line. There increased awareness of the providers, increased knowledge around dosing, route of administration, increased proper practice around heat-stable carbetocin, transportation and storage, and also their perception and experience around those set variables. And in summary, just to say that it is feasible to introduce heat-stable carbetocin. It's easy to administer and can be introduced safely with proper training of the healthcare providers. It is acceptable to both clients and providers. I would like to acknowledge our partners and special appreciation to MSD, who was able to fund us to do this work. Thank you.
Olatunde, you are going to speak or we move on?
Yeah, I am going to speak. Yeah. Thank you, Daisy. I'll present the Nigeria Smiles on Mothers work briefly. So for context, this research was also funded by MSD for Mothers, and we conducted this in 3 states in Nigeria, located in North as well as Western Nigeria. For context, Nigeria contributes a large burden to PPH and maternal deaths in the world. So for us, uterine is a leading cause of PPH. And so bringing in a new product that could speak to issues around poor quality uterotonic was very important. And to carry out this and then provide an enabler environment for this, the National Essential Medicine List, as well as the State Essential Medicine List between 2020 and 2021 were updated to include heat-stable carbetocin for use for PPH prevention. The training curriculums were also updated with support from Smiles for Mothers program. And so riding on this, another hypothesis for the implementation research was that adding heat-stable carbetocin to the current uterine tonic mix in Nigeria will not be associated with a significant change in clinical practice relating to PPH prevention as well as treatment. And we also posited that HSC will not be acceptable to clinicians, and there are no enabling environments for this. So the aim generally was to provide context-specific research evidence for safe and effective use of uterotonics for prevention as well as treatment of PPH, and scaling up other innovations in Nigeria. We also had specific objectives, which was to assess the current clinical practice for the use of heat-stable carbetocin, oxytocin, and misoprostol in public facilities in the secondary and tertiary level of care in Nigeria. I must say that before this, heat-stable carbetocin wasn't in use in the public sector. We had Pabal, which was the variant, but it wasn't in wide use. Our second objective was to investigate the acceptability of HSC by provider for use for prophylaxis in PPH prevention. And finally, to understand the factors that enable appropriate use of uterotonics for care in health facilities in Nigeria. So for our scope, we worked in 18 secondary and tertiary facilities spread in the 3 states. We had 6 facilities per state. This implementation research was conducted between June and October 2022, and our major variable was acceptability of heat-stable carbetocin for PPH prevention. Of course, we have core variables which included issues around quality, effectiveness, efficacy, as well as cost. We had analysis conducted on our data, which were mixed, quantitative as well as qualitative data. So we have descriptive analysis and as well as we did analyze using NIVO. And we had the ethical approval from both national as well as the states we are working in. The results that we got Next slide, please. And to speak to the pattern and trend of uterotonics used by healthcare provider, we found that there was the use of uterotonics for PPH prevention singly as well as in the combined form, majorly oxytocin combined with misoprostol. But for the 1,024 patients that had uterotonics administered for active management of labor, 90% of them had just one single dose of uterotonics. We had combination in at least one uterotonics, 93% had at least one uterotonic, and we had 31% of cases with 2 or more uterotonics administered to prevent PPH. Its stable carbetocin came out tops as the uterotonic that were used mostly for single dose, and oxytocin came in second, and misoprostol in 4% of patients. So when relating to acceptability and speaking to acceptability by healthcare providers, we did find that 75%, 76% of them preferred HSC as part of as a uterotonic option for PPH prevention. But added to that was that 97%, a very significant high number, were happy that it was available for use for PPH prevention. And if given a choice, 94% will be willing to use HSC to prevent PPH. Contributing to this were, of course, the high safety profile perceived by healthcare workers from their use of HSC, the efficacy which was equal to oxytocin, a good quality oxytocin to say. Costs as a contribution factor was for 43% of providers, not really a significant issue. At the time of implementation, HSC and oxytocin by pattern of use were almost about the same, costing the same to each woman and to the system. So factors that now determine how healthcare workers select uterotonics for use, as well as how they use it for prevention. We did find that guidance by senior colleagues that were met at the job contributed 76%. In-service training as well as workshop, why on the job contributed 76%. Mentoring, the healthcare water field mentoring really did contribute a high percentage to what they do, which was 84%. But significant for us was that the availability of job aids and charts on the wall where the healthcare workers were providing care, provided 100% in knowledge, awareness, and contributed to skillful use of HSC as well as the other uterotonics for PPH prevention. So just seeing that on the wall and being able to relate or look at that allowed them to make decisions as to what to administer during active management of the stage of labor or as well as during treatment of PPH. Next slide, please. So for our key takeaway from the study that we conducted, everything did point to having high quality, accessible and affordable uterotonics available for use for prevention as well as treatment of PPH. So as relates to its stable carbetocin, it was acceptable and said to be appropriate for PPH in facilities across the states we implemented in. HSC was found to be cost-effective, both efficacy and relative costs to the other uterotonics, and so was viable as an option for health systems to adopt for PPH management. And finally, structured as well as regular on-the-job training and mentorship really does contribute a lot to healthcare workers providing appropriate and rational care, and as well as rational use of uterotonics for PPH management. Thank you very much for your time. Over to you, Metin.
Thank you, Olatunde, and thanks for finishing on a timely basis as well. Let's move on to UNFPA and Catherine. Catherine Schulte-Hillen is going to give us the experience in Uganda and South Sudan. Catherine, over to you.
Thank you, Metin, and thank you everybody for attending this webinar. I'm trying to get this full screen. So UNFPA led a study of the introduction of heat-stable carbetocin and tranexamic acid in 12 BMONC, so basic emergency obstetric and newborn care facilities, half of them in South Sudan and half of them in humanitarian settings in Uganda, together with UNHCR in the refugee affected areas. The study was done from May 2022 to the same time 2023. It had all the different ERB approvals. And you see the different investigators, including Dr. Tuan Tran, who's the main investigator, and then country level and study principal investigators. The study was funded from Ferring Pharma, both with funding for the study itself and in-kind contribution of heat-stable carbetocin, and the UNFPA supplies partnership with funding for the study and the funding for the tranexamic acid. If we look at the study focus, it was very clearly indicated by the need to understand how we could introduce heat-stable carbetocin and TXA into the current interagency reproductive health supplies that are sent to humanitarian settings. So what we try to do is to identify a package of HSC and TXA inclusive PPH interventions that would be designed to strengthen existing basic obstetric services in humanitarian settings, and to evaluate that package effect on trends in the use of uterine tonics, including heat-stable carbetocin, as part of active management of third stage labor, and the use of uterine tonics and TXA for PPH treatment. We want to evaluate the package feasibility by understanding the operational enablers and barriers in these low resource settings, basic emergency obstetric care facilities in humanitarian settings. And finally, we wanted to inform the discussion and decision-making regarding the integration of heat-stable carbetocin and TXA into the interagency reproductive health kits at BMONC level and CMONC level later also. And you get some feedback on that at the end of the presentation. This is just to say that the study we undertook was really focused on the humanitarian settings and on the most basic level, so the BMONC level. All facilities were within that. The overall design was a multi-phase and mixed method design. Not going to go into all the details of it. We can look at some key features of the study later on. What was key in the whole approach was the training approach. It was like with the other studies that you've seen, it was very clear that introducing new molecules alone would not do it, and that we really needed to take this opportunity to work on the understanding of PPH prevention and management, both at a knowledge level and as a skills or competencies level, so everything that is the skills drills. For the overall approach, we decided to use a training approach which already exists and had interagency approval. So the Helping Mothers Survive BBAC2 approach, the one that already includes TXA and heat-stable carbetocin within its training material. As I said, the content of the training was not only the introduction of the two new molecules, but everything, including the intrauterine balloon tamponade and all of that. So really using the possibility, this opportunity to do a refresher for all the relevant stuff. And then the training methodology, we chose a low dose, high frequency, starting even before we had people in the field, with webinar engagements, understanding people's knowledge levels, then in the field during the study and after the study with refreshers, with the introduction of different molecules. And overall, the study enrollment had nearly 5,500 women, with 3,100 in South Sudan and 2,300 in Uganda. We did a phased approach. We did the capacity building. So we had the baseline assessment based on patient files and documentation prior to the first training. Then the training, 4 weeks without any introduction of molecules, a refresher, introduction of heat-stable carbetocin, observation of another 4 weeks, and then introduction, refresher and introduction of TXA. And in the end, we do think that a phased approach, if feasible, is probably a very good idea. Some of the key findings include, so active management of third stage labor was in general reported in facility at baseline pretty much 100%, mainly oxytocin, but also at the time already providers said that they used kind of a mix. If they had a mom who's a, fifth para or somebody with twins and they were worried about PPH already when the woman was in labor, sometimes they would immediately take a mix and, give some oxytocin, some agamiflozin, some misoprostol. And the main statement was because there's not actually that much confidence in the capacity or in the effectiveness of oxytocin. So I think as such, that was already quite an important statement. There was at baseline, no heat-stable carbetocin or TXA used in any of the facilities prior to the study beginning. When we introduced heat-stable carbetocin, the uptake was very, very strong, so nearly 100%. There were in the data, and I spare you because you have it in the study, I spare you all the data here. But there was a problem with stockout at one point, so people switched back to oxytocin, but that didn't take a very long time. There was and you'll find that in the qualitative study, a high provider appreciation of heat-stable carbetocin. The feedback was pretty much immediate, that people were very happy with the effectiveness of heat-stable carbetocin. They even went as far as saying they felt that it reduced the emergence of PPH. So we don't have any data on that one, but it's very clear that the providers themselves were appreciative and really wanted to continue the use of heat-stable carbetocin for Amstel. There was an observation of reduced oxytocin use for PPH management when we introduced the TXA. There was a confusion, even though the training was very clear, but as the heat-stable carbetocin replaced the oxytocin, there was maybe a reflex that TXA might replace oxytocin. With the very close monitoring, that was identified immediately and rectified, but there was like a dip in the oxytocin use. People started taking the TXA, but dropping the oxytocin for PPH management. Overall, there were no adverse effects during the entire study period. I think that is the important piece. Lessons learned from the research. So very clearly, the heat-stable carbetocin can replace oxytocin for PPH prevention in cold chain challenged settings. Provider uptake is very, very easy, very appreciative, and with adequate training, that isn't a problem at all. Tranexamic acid, the main message for us in the study was that we need to really hammer in the message that it does not replace oxytocin for PPH treatment. That we had that in both countries, so it's something that really we need to keep an eye on. And for both together, as my colleagues have already underlined, it's feasible and acceptable for providers in a phased introduction. In our case, we did the phased introduction of first heat-stable carbetocin and then TXA. And remember, it's BMONC level, so TXA had been already available through the interagency kits at CMONC level, but not TXA at BMONC level. The overall learning, it really requires investment in staff capacity development, data, data follow-up, supportive supervision, and program monitoring and evaluation, especially in the introductory phase where there might be misunderstanding, and then you have something like, dropping oxytocin to only use TXA for the PPH management. And I think that the introduction requires some monitoring. I think we've seen that in all the different studies. You can't just put out a new molecule or a new way of working without doing the monitoring. Some key features of the study. So integrative, as explained, not with a sole focus on the introduction of new molecules, but with a recognition that overall PPH prevention and management is weak and that we need to invest. Strengthening of existing health systems, so supporting childbirth services and helping providers to follow national guidelines in introducing these new molecules. The package strategy, so bundling together different intervention into a package. Low dose, high frequency training strategy. We looked at the scalability. We did not introduce any new staff, and we worked with existing modalities. And that's, particularly if you think about everything that is data collection, we worked with patient files and the maternity registers that are in place and tried to find a space within these registers where we could adequately reflect the introduction of the different molecules rather than having separate paperwork, because we found that on the scalability, that was not something feasible. The design you saw, complex multi-phase, very much in a participatory approach with validation workshops in again, and really trying to get buy-in at a national level. And I'll come to some of the, let's say, reflections in regard to that later. As I mentioned, our level focused on BMONC. Prior to the study, we did scoping reviews for heat stable carbetocin and TXA regarding existing studies, and saw that basically all studies concentrate on CMONC level and concentrate on more stable settings where we really wanted to be at BMONC level and in the fragile humanitarian settings. And as I said, the humanitarian settings that were spread out in South Sudan and then located in Western Nile and Western regions in Uganda. I'm not going to go through all of this, but just to say that the study also allowed us to learn some lessons and to prepare and share reflections with the national teams at both sides, so the Ministry of Health teams, regarding all the points that would be necessary for them at national level to prepare in order to introduce smoothly these new components. So from guidelines and pre-service trainings to where do you actually register it, the modifications that are necessary in maternity and patient records and things like that. And then at health facility level, also guidance on what are the key issues that need to be done at health facility level to ensure readiness for those supplies and for the continuity and the, avoiding stock rupture. Some reflections on next steps, and maybe I'll hover a little bit on that one, because now that more than a year has gone by, we do see that there's, it's really complicated to get these different molecules into the markets that we would be interesting to see them. It's also complicated to see that after the effort and the momentum that was created through the study in Uganda and South Sudan, it was difficult to find a continuity. So some of you might know there's an EU funded Safe Birth Africa project, a big project with JPIGO, Unit 8 and UNFPA. And I'm very happy to see that that project has picked Uganda as a place. So there's some continuity that we were able to kind of negotiate for Uganda. Amplify obviously is in quite a few countries. And then there's the small grants that Milka administers through the reproductive health supplies, where we did manage to get some support to South Sudan. But the continuity after the studies, because we're in humanitarian settings, was particularly worrisome, because you create an expectation and momentum. The providers really like the approach, and then the study stops and there's no follow-up to that.
Catherine, I think we need to wrap up,
okay,
because otherwise we won't have time for other speakers.
Okay, I'll share, I'll share the, you see the main reflection.
Share the slides, yeah.
Yes, you see the slides, and that's also the end of the presentation. So I think there's there's some takeaways on additional learnings. How do we introduce drapes? And then what do we do in humanitarian settings, investment in the future, and underline just the huge importance in everything we do in this, in training, monitoring, and supportive supervision. And sorry for being too slow. Thank you, Metin.
No, you were not too slow. It's just the previous presentations went over time as well.
Okay.
Thank you. Harish, 5 minutes. It will be strictly no more than 5 minutes. Please go ahead. Otherwise, we won't be able to finish. Thank you.
So now we have Dr. Harish Kumar, who is going to be presenting on the feasibility and optimal use of heat-stable carbetocin in Madhya Pradesh state in India. Dr. Kumar, it's your turn. Thank you.
Thanks, everybody, and good evening, good morning, and at various time frames globally. I'm Dr. Harish Kumar, working on behalf of Sambek project, which is a USAID supported project in India. And we tested the feasibility and optimal use of heat-stable carbetocin in public setting of Madhya Pradesh in Devas district. Basically, PPH continues to be a major killer in India. And if I have to say that PPH stands in the way of India achieving SDG. Heat-stable carbetocin was approved by DCGI in 2021, but it has no experience of use in the public health system. Although in the private sector, almost 1 million dosages have been used. So to guide our public health system, we did this work with the objective whether is it possible to ensure the appropriate use of carbetocin injection in public health facilities. For there were some concerns expressed that whether carbetocin will be used for induction of labor or augmentation of the labor. And second, we wanted to understand the barriers and facilitators that can inform the implementation so that our model of demonstration can pave the way for scale up in the country. What we did was that we used a human-centered design implementation framework where we used our discussions with the stakeholders, state governments, providers, and beneficiaries. We try to address the right problem, for there have been some reports that have expressed doubts on the quality of oxytocin, and the people who have been trying to advocate for the alternate, there have been concerns related to its appropriate use. We wanted to implement a model where it is implemented through the health system strengthening approach, that we wanted to use the service provision of the country's system, existing drug supply chain, existing data collection, recording, and supportive supervision, so that we don't start anything vertically, for which we didn't want that we try to make our model such an expensive model that it is difficult for the country to scale up subsequently. And lastly, we wanted to start small, but with simple interventions, such as developing partnership with private providers, capacity building so that it can be further scaled up, and monitoring based on the gap identified in the monitoring of the state system. So for this, we use collaborative learning and adapting approach, which was used during the implementation. Basically, 3 major tasks which we did were included a partnership with the government, which provided us access to Devas district, Ferring Pharmaceutical, which provided us the drug, and as USAID Sambek project, we provided them the public health implementation support. We created job aids so that we could do capacity building in a participatory methodology using quality of care, person-centered care approach. We use AMTSL as an entry point based on the assessment, which showed that 30% providers hadn't been trained at all. And we wanted to focus on all the components of AMTSL besides ultrasonic. And lastly, we wanted to add evidence-based do's and don'ts to prevent happening of postpartum hemorrhage. We assessed the drug supply chain, which was found to be adequate at majority of the places, so that probably the fault lied in during the manufacturing process of oxytocin, and we wanted have a look at the data recording mechanism, which can be subsequently scaled up. And the major gaps identified included that the timing of utrotonics was not being recorded. So we took care of all those deficiencies and put it into implementation across all levels of the health system so that country can take an informed choice whether to implement at only FRU level or non-FRU or across the state. Since this is an ongoing model, we shared the results recently, which have been published, of the initial 15 facilities, which were responsible for 80% of the delivery load of the district, which included 2 first referral units and 13 non-referral units. During this period, heat stable carbetocin was provided to 17,861 deliveries, majority of which were normal, but approximately 17% were cesarean deliveries. We could ensure, without adding extra HR, that 99% coverage of utrotonic and almost universal coverage within 1 minute. There was no instance recorded of using heat stable carbetocin either for induction of labor or for management of PPH. 2.5% of the cases, contraindications were recorded, and I have no shame in sharing that such contraindications were never being used for oxytocin, even though the contraindications for heat stable carbetocin as well as oxytocin were similar, and there were no adverse drug impacts which were used. Major difference lied in terms of the PPH. While PPH was noted to be in around 0.5% of the cases, but 0.6% of the cases where heat stable carbetocin was used, and almost 5 times higher in the groups where oxytocin was used. The major cause of PPH included atony, which was found to be almost 70%, which is as per the findings from other global places. We could find an instance of blood transfusion to the tune of 3%, and tranexamic acid almost given in 81% of the cases, while 16% of the cases were referred. The state decided after the first year of implementation to expand its use. Multiple states have included in the essential drug list. MP government have written to the national government for its scale up. The major learnings which we acquired included that the existing drug supply chain can handle carbetocin and there were no stockouts. Drug wastage was almost negligible. No major events were reported. So it is possible to ensure its optimal use, and it was not used for augmentation. And this can pave the way as and when the government takes a call of reducing PPH, both morbidity as well as mortality. For our initial implementation data showed that there have been almost 20% reduction of PPH mortality and almost 33% reduction in the blood transfusion rates across the district. Thank you.
Thank you very much, Dr. Harish Kumar, for this wonderful presentation. I'm curious on one thing. What are the contraindications for heat stable carbetocin? You mentioned that it was not given in some cases because of contraindications. What were they?
See, basically, if we look at carbetocin is a drug which is similar to oxytocin, but
Right.
with a longer duration of action. And majority of the contraindications which have been referred to by the drug manufacturers included such as pregnancy-induced hypertension, convulsion, severer cases of liver diseases, or any other neurological findings. So these cases, what has been happening in the system is that they haven't been paying least heed to such contraindications. And we do not yet know whether if oxytocin is given in these contraindications, how much adverse effect is it causing to the patient? What it has started is that with heat stable carbetocin, we have been able to do quality improvement in terms of AMTSL practices, and secondly, also bring the attention of the system people towards some of the side effects of oxytocin or oxytocin-like drug like carbetocin may have, where more emphasis is needed in the countries.
Okay. Thank you so much. So now it's the time for our next presenter. Thank you. And just a second. Now it's the turn of Dr. Fatou Forna, from the CEO of the Mama Pinkin Foundation from Sierra Leone. And I should also mention that the Mama Pinkin Foundation is receiving funding from the New and Lesser Use Medicines Catalytic Opportunity Fund, generously funded by Merck for Mothers and FCDO. So, and they have also received a huge donation of uterine models from Laerdal, and we're very, very happy to have you here today, Dr. Forna. So please go ahead.
Thank you so much, and good morning, everyone. I wanted to talk briefly about the key takeaways from the 9-country implementation research studies, and then talk a little bit about our experience in Sierra Leone so far. So we've listened to all of the other speakers today, who've talked in depth about these 8 original research studies that were done in 9 of the LMICs: Burkina Faso, Ethiopia, Ghana, India, Kenya, Nigeria, Sierra Leone, South Sudan, and Uganda. And, these studies, captured over 126,000 women, done in 103 health facilities, and involving 678 healthcare providers. And what has been shown over and over again, the research, of course, assessed the safety, the acceptability, the feasibility, and appropriate use of these medications, HSC and TXA. What are the key research findings? We have seen in the 5-country, in all of these studies, of course, are in the supplement, in the 5-country implementation pilot, in 5 countries, they showed safe and appropriate use of HSC and TXA in BMONC and CMONC facilities, that these drugs can be safely and appropriately integrated into immediate postpartum care in cold change challenge settings. The Nigeria study showed that use of HSC for PPH prevention is acceptable to healthcare providers and has been found to be effective with a very high safety profile. The Kenya study showed that healthcare providers had favorable experiences using these drugs, and that policymakers found value in its introduction. In the India study, we saw that it was feasible to introduce HSC and that it could be appropriately used for PPH prevention in the existing health system. In humanitarian settings, we saw where HSC and TXA was implemented in South Sudan and also in Uganda. So I think we have varied experience using these drugs in multiple different countries around the world. And our key takeaways are that while most of the healthcare providers had favorable views on both medications, health system adaptations are needed to ensure optimization of use and sustainable scale-up. We saw that establishing a structured system of regular on-the-job training and mentorship for healthcare workers on PPH prevention and management and other areas of maternal care ensures the appropriate use of uterotonics and improves the maternity experience. That capacity building of healthcare workers on active management of the third stage of labor will increase the effectiveness of care, and that a comprehensive training strategy to integrate these drugs in humanitarian settings increases the knowledge and skills among healthcare providers and empowers midwives as leaders. And finally, that policymakers really do find value in the introduction of HSC and TXA into the public sector. I wanted to talk a little bit about our experience in Sierra Leone, how this research is translating into practice. Of course, Sierra Leone has very difficult cold chain challenges, even in the referral hospitals in the country, have very, very inconsistent electricity. So there was a lot of interest and a desire to bring in these drugs. For HSC and TXA, we introduced them in Sierra Leone for the very first time in September 2022. There had previously been very few areas that had TXA in very, very limited numbers, but HSC had never been introduced in the country before. So this is a picture in September 2022 of the first patient receiving HSC in Sierra Leone that was part of that 5-country implementation pilot study. In 2023, the Mama Pikin Foundation supported the Ministry of Health as a follow-up to that pilot. They supported the Ministry of Health to develop a national roadmap for scale-up of use of these drugs in the country, and the organization received the Catalytic Opportunity Fund grant, as was mentioned, to help introduce and scale up these medications. This was, some of the training of use of the drugs, this picture. So phase 1, Sierra Leone has received 2 grants to date. The phase 1 grant was used to support the development of a national training package for use of HSC and TXA in the country. So this picture was from February 2024, when the national stakeholders, all the national stakeholders throughout the country convened. And there was a national stakeholders adaptation and validation workshop where they worked on this national training package, adapted it and validated it for use in the country. Part of this phase 1 grant also supported the development, this phase 1 grant that supported the development of the national training package for use of the drugs. In July 2024, all of the training materials for training the healthcare workers throughout the country were printed, and this was a symbolic handing over of some of the training materials to the stakeholders within the Ministry of Health. Well, the phase 2 grant that was used to support the national training of the trainers using that training package, and also to train health workers in 8 of the 16 districts in the country. So this phase 2 grant, we're in the midst of it now, and this kicked off in September 2024 and will go on until February 2025. And these pictures showed the national training of the trainers that was held in September, and the second picture shows one of the first training in the first district. This work is currently ongoing to train healthcare workers in those first 8 districts in Sierra Leone. HSC has been purchased through partnership between UNFPA and the Ministry of Health. 19,000 doses have been purchased, are in the country. Another 19,000 are in the pipeline. 35,000 doses of TXA have been purchased, and these medications are being deployed throughout the country in tandem with the training. So this is just an example from Sierra Leone how, we started this process with the pilot, and as a result of the pilot, worked with the Ministry of Health to have this national plan that cascaded into the national training, and we're now in the process of hopefully training all of the healthcare workers in the country and making that transition into using HSC for the active management of the third stage of labor and TXA for management of postpartum hemorrhage. This is a QR code of the PPH implementation research, the special collection that has all of those studies that we've discussed about today. So thank you very, very much.
Thank you, Dr. Fatou, for this wonderful presentation. I'm so glad that we have been also part of this wonderful progress in Sierra Leone. All the best, and thank you so much. Let's continue with our webinar.